Welcome to the Introduction to the Hospice Quality Reporting Program webinar. The audio for today's session is available by telephone or audiocast. Audiocast quality is subject to equipment, bandwidth, and internet traffic. If you experience unsatisfactory audio quality, please use the telephone dial-in option provided in your confirmation email. If you do not see the phone number in your webinar email, please send a message to the operator using the Ask Question button to the left of the presentation. You will receive a response by email. Assistance is available to those on the telephone by pressing £0. You may send questions or comments at any time using the Ask Question button on the left of the presentation screen. Then click Submit to submit your question. Individual responses to specific questions will be sent by email. Questions of general interest will be posted in the Q&A box, which can be viewed by everyone by clicking the Q&A button on the left of the presentation. A Q&A document will be distributed after the webinar addressing questions on today's topic. A PDF of the slide presentation can be accessed by clicking the Materials button on the left of the presentation. Please note, the presentation displayed on the screen has been revised since the handout was posted, so the slide numbering may not match exactly. I will now turn the call over to Sharon Purcell. Please begin.
Good afternoon, everyone. Thank you for joining us today for the Hospice Quality Reporting Program Overview webinar. My name is Sharon Purcell, and I will be your host and moderator today. Now I have a few housekeeping items, but please note, due to technical changes, housekeeping information may be slightly different than what was posted on the Hospice Quality Reporting webpage. This webinar is being recorded. It will later be posted to the CMS Hospice Quality Reporting Program website. We will provide you with details on accessing the recording via email when it is available. Closed captioning is enabled and will appear at the bottom of your screen. The audio can be controlled by using the speaker icon on your computer taskbar in conjunction with the audio control on the webinar platform. The phone lines will be muted for the duration of the presentation. Due to the large number of attendees on today's webinar, we are unable to field questions over the phone, but you are able to submit questions electronically. If you have a question at any point throughout today's presentation, click on the Ask Question button on the left of your screen and click Submit. We will answer as many questions as possible during the presentation. Responses to all submitted questions will be published on the Hospice Quality Reporting Program webpage. An email will be sent to you when the Q&A document is available. Responses to technical questions will be accessed by clicking on the Q&A button. If you would like to download today's presentation slide deck, click the Materials button located on the left of your screen to access the shared files. The presentation slide deck is also posted to the Hospice Quality Reporting Program website in the Downloads section. Now I'd like to introduce our speakers for today. Presenting the Hospice Quality Reporting Program overview are Brenda Karkos, Cindy Masuda, and Deborah Whitaker. Brenda Karkos is an Associate Nurse Researcher at APP Associates. She is an RN with many years of clinical and administrative experience in community health, hospice, and oncology. She is certified in hospice and palliative care and currently serves on the Board of Directors for the Hospice and Palliative Care Federation of Massachusetts. Before joining APP, Brenda was most recently the director of a hospice program in Massachusetts. Her work at APP is focused on hospice, oncology, and home health projects. Cindy Masuda joined Centers for Medicare and Medicaid Services in 1999 as an IT lead and responsible for inpatient prospective payment system payment policy in the Centers for Medicare Management, Division of Acute Care. Cindy has worked on Medicare demonstrations with a focus on hospice. She was the project officer in CMS's Office of Research, Development, and Information, now Centers for Medicare and Medicaid Innovation, CMMI. Rural Hospice demonstration from 2005 through 2010. Cindy Masuda brought her subject matter expert on hospice as project lead project officer for the design of the Medicare Choices model. She joined the Centers for Clinical Standards and Quality, CCSQ, in 2015, where she is the Hospice Quality Reporting Program coordinator. Deborah Dean Whitaker serves as the contracting officer representative for the Hospice CAHPS Survey and for the In-Center Hemodialysis Survey. She has been with CMS for nearly 5 years. Prior to working at CMS, she worked at a government contractor and also for 17 years had her own research business. Deborah received her Ph.D. from Indiana University in American State and Local Public Policy. A disclaimer has been provided for your review. Please keep in mind Medicare policy changes frequently, and please refer to the links provided in the presentation for the source document. We encourage you to review the specific statutes, regulations, and other interpretative materials for a full and accurate statement of their content. On the next slide, slides 7 and 8 in the slide deck, it contains a reference list of acronyms that will be used throughout today's presentation. We will conclude today's webinar with a question and answer session and finally a wrap-up. We are pleased to have such experienced and knowledgeable speakers present on today's webinar. Deborah, Brenda, and Cindy, thank you for being here. It is now my pleasure to turn the session over to the presenters. Brenda, Cindy, and Deborah, the floor is yours.
Hi, my name is Cindy Masuda, and I just wanted to introduce myself to everybody and thank you very much for joining us today at CMS for this very exciting and very informative webinar on the Hospice Quality Reporting Program. It's a primer to go through the Hospice Item Set and the CAHPS Hospice Survey. This is one of many webinars that we offer. We offer training at least quarterly here at CMS for the Hospice Quality Reporting Program, and we're very proud to be able to do that. And as the Hospice Quality Reporting Program coordinator, always looking for ways to provide useful information and to be as user-friendly and as accessible to our provider community as we can possibly be. So this webinar today is one where we are following for the Hospice Item Set. We are following the Hospice Manual, which makes it a very useful approach for training, and it's a way to present the materials so that so that users for a variety of different learning styles can follow along and use our different trainings to fit their learning style. We also have Deborah Dean Whitaker here, who will be speaking on the CAHPS Hospice Survey, since she is lead for that part of the Hospice Quality Reporting Program. And I just want to make sure people are aware that this webinar, as talked about at the beginning, we post everything on our Hospice Quality Reporting Program webpage. We have our Spotlight page where we announce everything going on in the Hospice Quality Reporting Program, and encourage you that if you are not already a member of our listserv, to please become a member of the listserv so you receive these email blasts announcing information that's on our Hospice Quality Reporting Program web pages. And this webinar, like all our trainings, will reside on our training and education web page, and we've updated those web pages in the last couple months so that all trainings that we provide are available in the download section as a zip file, so that in one-stop shopping, you're able to locate the audio, the webinar, the video, and the handouts that go along with our training. So very much appreciate that we set up these trainings for your benefit, and you always have the opportunity to let us know of trainings you would like to have. We actually set up trainings based on feedback we receive from you. So look forward to that kind of dialogue, along with any other questions you may have about the Hospice Quality Reporting Program. We're always here and always available to answer your questions, and look forward to your communications. It's what helps make this program as robust as we can possibly make it, and to be as coordinated with our provider community as we possibly can. And with that, I'm going to turn it back over to our moderator so that we can get started with this exciting program, with this training today. Thank you very much.
Okay, thank you, Cindy. So this is Brenda Karkas. I'm going to get us started in the first section, and we're going to talk about what is hospice quality reporting. What is that hospice quality reporting program? So first, I'd like to review the learning objectives for this first section, which is an overview of the HQRP itself. Our key objectives are that you'll be able to define the basic components of the HQRP, that you should be able to explain the program's general compliance requirements, and then you should be able to summarize the effect of noncompliance on the APU. So Section 3004C of the Affordable Care Act directs the Secretary to establish quality reporting requirements for hospice programs. So currently there are two reporting requirements for the HQRP, and that is the HIS and the CAHPS. So here's a graphic that displays that best and shows you what makes up that hospice quality reporting program. So the HQRP requirement includes both the HIS and the CAHPS. And all Medicare-certified hospice providers must comply with both of these components in order to meet the requirements. So let's review the purpose of the HQRP and why it is important for hospices to collect and submit this information. The HQRP promotes the delivery of person-centered, high-quality, and safe care by hospices. Hospice providers can use the HQRP data to identify opportunities for improvement and track their progress as part of their quality assurance and performance improvement programs, or QAPI. Consumers can access quality information on a public website called Hospice Compare, where the public can find hospices that serve their area and compare them based on the quality of care they provide. CMS makes multiple provider reports available through which you can preview your hospice's data before it's made available to the public. So the HIS is a standardized set of items intended to capture patient-level data on each hospice patient admission. HIS data collection consists of selecting responses to the HIS items in conjunction with the patient assessment activities, or through abstraction from the patient's clinical record. Hospices must submit 2 HIS records, an admission record and a discharge record for each patient admission. The next slide shows 2 tables that list what's included in each of these records. So on this table, you can see the sections included for each of the 2 hospice item sets, the HIS admission and the HIS-Discharge records. The admission set includes 6 sections, sections A, F, I, J, N, and Z. Sections A, I, and Z are more demographic and administrative types of questions, such as the provider number for the hospice, patient's Medicare numbers, the active diagnoses, and the name of the person completing the actual HIS record. Sections F, J, and N focus on the care processes, such as asking about the patient's treatment preferences, the presence of pain or dyspnea, and whether the opioid medication was initiated or continued. The discharge HIS includes only 3 sections, and these are A, O, and Z. Section O is the newest section, which asks about hospice services provided in the last 3 and 7 days prior to death. We're not going to go into detail regarding each of these sections. However, if you do need more information regarding these, please visit the CMS HQRP website. And through that website, you can access details regarding the HIS and lots of other great information on the Hospice Quality Reporting Program. And you can also view previous webinars and recording trainings, as Cindy mentioned, that include some clear instructions regarding completing the hospice item sets. And all of these resources will be listed at the end of this presentation. So HIS data are collected and submitted on all patient admissions, regardless of the payer, the patient's age, or where hospice services are received. It's recommended that hospices complete the HIS no later than the admission date plus 14 calendar days, and after discharge, no later than the discharge date plus 7 calendar days. However, this is a requirement. It is a requirement that the hospices submit the HIS admission or discharge data within 30 days. So there's a recommended timeline for completion, and then there's also the actual submission timeline, which is a requirement. And that is going to be the admission date or the discharge date plus 30 calendar days. The other component of the HQRP is the CAHPS Hospice Survey, which measures how patients and their caregivers experience hospice care. The CAHPS Hospice Survey is composed of 47 questions, and it's administered by a third-party vendor to the primary informal caregiver of the person who died while receiving hospice care. The CAHPS is available in several languages, and it's administered using 3 different modes. It can be mail only, telephone only, or mail with telephone follow-up. The vendor that is chosen by the hospice submits the results of the survey to CMS on a quarterly basis. So here is just a list of the topics that are included in the CAHPS Hospice Survey, and these are the communication with family, getting timely help, treating patients with respect, emotional and spiritual support, help for pain and symptoms, training the family to care for the patient, rating of the hospice, and the willingness to recommend the hospice. So there are circumstances in which CMS may grant an extension or an exemption when a hospice is unable to submit quality data due to extraordinary circumstances beyond their control, or when a systemic problem with CMS data collection systems directly affects a hospice's ability to submit the data. For example, a natural or human-caused disaster can prevent timely submissions of the quality data. In such cases, CMS may grant an extension or an exemption. So in an extension, the submission deadline is extended for up to 45 days beyond the scheduled due date. CMS can also grant an exemption, which means that the submission of the data is waived for a specific time period. When exemptions and extensions are granted, they do maintain the provider's HQRP compliance. Exemptions and extensions can either be provider-initiated or CMS-initiated. For those that are provider-initiated, a hospice can initiate a request by sending an email request within 90 calendar days of the date that the extraordinary circumstance occurred. That email must include supporting documentation that demonstrates the need along with the CMS CCN number. And the request must include facts and circumstances leading up to the request, such as the date or the dates of the occurrence, what actually happened, and any other documentation that could support the rationale for this request. It's important to include as much as possible since the determination by CMS is based solely on the documentation that the hospice provides, and they will not be contacting the hospice to request additional information if it's not complete or if it's inconclusive. For CMS-initiated extensions or exemptions, these are based on natural disaster areas in response to hurricanes, floods, earthquakes, or even fires. And in these circumstances, CMS will notify hospices through the routine channels, such as the CMS website under Spotlight and Announcements. If CMS initiates a waiver, you don't need to take any action since the exemption or the extension will automatically be granted. However, you do need to check the CMS website to be sure that the waiver actually pertains to your hospice. And if you're found to be noncompliant, you would need to submit proper documentation regardless of whether you think you meet an extension or exemption for HIS or CAHPS. There's a lot more information on the CMS website under extensions and exemptions, so I would encourage you to take a look at what's there. So what does CMS do with all this HIS and CAHPS data? One use is to make the information about each hospice available to patients families, and other stakeholders on the Hospice Compare website. The Hospice Compare website includes HIS-based quality measures, or QMs, and the CAHPS Hospice Survey data. There is something else that CMS does with the data. CMS monitors each hospice provider's compliance with HQRP requirements to determine whether they will receive their full annual payment update, or APU. And since there are two requirements for the HQRP, hospice providers must meet the individual requirements for both the HIS and the CAHPS to be compliant with the HQRP and avoid the 2 percentage point reduction in their APU. There's no partial credit. If a hospice only meets one of the requirements, their hospice would be considered non-compliant and be subject to the 2 percentage point reduction in the APU. So timely and complete data must be successfully received by CMS in order for the hospice provider to be considered compliant. So let's just do a quick knowledge check on this first section. Select the two components of the HQRP requirement. Is it A, HIS and QAPI, B, QAPI and CAHPS, C, HIS and CAHPS, or D, APU and QM? So I'll give you a minute to just think about it, think about your answer, or talk to someone else in the room if you're with other people. Okay, so why don't we give you the answer? So the two components of the HQRP requirement are C, HIS and the CAHPS. So C is the correct answer. So in this section, we discuss the HQRP, we define the basic components that it includes, and you also learned about the general compliance requirements of the HQRP and the effect of a non-compliant hospice, and it would affect your APU. In the next section, we're going to break down these components a little more and go into much more detail. So now let's move on to Section 2, the Hospice Item Set, or the HIS. It's also called the HIS. And let's just start with reviewing the learning objectives. The key objectives for this section are that you'll be able to describe the record types that comprise the HIS and identify the three phases of HIS reporting: the data collection, record conversion, and then the HIS record submission. You'll also be able to define the submission thresholds for compliance in FY 2020 and beyond. So in the last section, we did talk about the components of the HQRP and that it's comprised of both the HIS and the CAHPS Hospice Survey. We're now going to focus on the first component, the HIS. It's important for all hospice clinicians to understand the HIS and the record types and how the patient assessment data they collect in the field is reported and then contributes to the overall Hospice Quality Reporting Program. So the HIS is a standardized set of items intended to capture patient-level data on each hospice patient admission. The data is collected on admission and then again on discharge and consists of selecting responses to these items in conjunction with the patient assessment activities or by extracting the information directly from the patient's record. It can be collected by any hospice staff member, such as a nurse, a social worker, the hospice aide, or a trained volunteer. The data collected includes administrative information as well as information about the care processes that take place on admission or discharge for the patients. In the table shown here, you can see the types of information that are collected on admission. So in Section A, administrative information, it includes items like the provider numbers, the site of the admission, admission date, legal name of the patient, payer information, and the zip code where the patient's residing while they're receiving services. In Section F, preferences, the HIS asks about the patient's preferences regarding life-sustaining treatments and spiritual care. And in Section I, active diagnoses pertains to the patient's principal diagnosis. So here's just some more information that's collected on admission. Section J is health conditions, and it pertains to the patient's physical symptom management. The physical symptoms included in this section are pain and shortness of breath. And then Section N talks about medications and gathers information on opioids and bowel regimens. And Section Z, record administration, contains the signatures of the individuals that are completing the HIS and of the individual verifying the HIS record completion. So now let's look at the data that's collected on discharge, and this includes, as I mentioned previously, Section A, Section Z. Those are both in the admission HIS, but it also has this new section, Section O, service utilization, which asks about hospice's utilization of services during those last days of life. So completing a timely assessment and accurately collecting the data is just the first phase of HIS reporting. In the second phase, the data must be converted into the proper electronic file format before it can be submitted. To convert HIS records into the proper XML file format, providers can use either the Hospice Abstraction Reporting Tool, or HART software, or a vendor-designed software. And the HART software is available free through CMS for their providers. Once the HIS records are converted, the files are then ready to submit to CMS. So now that we've talked about the data collection and converting this to the correct format, let's look in a bit more detail at the submission process and who needs to submit this data. So to comply with the HQRP, it's important that the hospice maintain regular and ongoing electronic submission of the data. This data is required for patient admissions to the hospice, and all Medicare-certified hospice providers are required to submit HIS admission and HIS-Discharge records for each patient admission to their hospice. The HIS data must be collected and submitted on all patient admissions regardless of the payer source, including Medicare, Medicaid, or private payer, the patient's age, or where the patient receives hospice services. For example, whether the patient's at home or might be in a nursing home, an assisted living, or possibly a freestanding hospice. The length of stay on hospice is also not a factor. So let's just talk about the admission record. For the purposes of completing the HIS, a patient is considered admitted to the hospice if the following conditions are met. There's a signed election statement, also called the Notice of Election, or NOE, or a similar agreement for a non-Medicare hospice patient. The patient did not expire before the effective date of the election or agreement for care, and the hospice made a visit in the setting where the hospice services are to be initiated. All three criteria must be met for the patient to be considered admitted for the purpose of HIS reporting. So in addition to completing and submitting the HIS admission record for each patient admission, hospices must also submit a discharge HIS for each patient. For the purposes of completing this discharge assessment, the patient is considered a discharge when the patient is no longer receiving services from the hospice or when there is an interruption in care or services. And some examples of this would be a patient expired, they may have revoked hospice services or are no longer terminally ill. They might have moved out of the service area for that hospice or been transferred to another hospice, or they might have been discharged for cause. So now let's talk about the reporting cycle. It's important to know that there are submission thresholds for the HIS reporting activities that are on a cycle. And the cycle spans over 3 years and consists of the data collection and submission, compliance determinations, and then the payment impact. So, for example, HIS data collected, submitted, and accepted on time during calendar year 2018 is processed for compliance determinations during that next year, calendar year 2019, and it will actually impact your hospice payment in fiscal year 2020. So this 3-year cycle is referred to as the fiscal year 2020 reporting cycle. The data you're collecting this year will impact your payment 2 years from now. the compliance threshold is 90% in the calendar year 2018, and this is the threshold that will affect your payment in 2020 and beyond. So this table just depicts that for that reporting year 2020, the HIS data is collected from January to December of 2018, and the threshold is 90%. So if you have questions about the HIS, if you'd like to know more about how to complete a particular section, you can refer to the HIS manual that's provided by CMS, and a copy can easily be accessed online. The link is shown here on this slide, and this manual provides important guidance for the completion of the HIS. So I'd like to just review a little bit of what you're going to find in the manual. So the HIS manual is divided into 3 chapters. The first chapter begins with the background and an overview of the HIS manual itself and covers the background and statutory authority for the collection of the HIS data and the HQRP. It also provides an overview of the manual itself, HIS requirements, applicable facilities or agencies, requirements for new agencies, and how admissions and discharges are defined for HIS reporting. And there's also information about the record types, the definitions, timing and sequence policies, as well as how to maintain HIS records and compliance with the HQRP. Now, the second chapter does contain a lot of detail about the specific items and instructions with some examples and tips for completion. And there's an overview of all the HIS items as well as rationale, which explains the purpose of the items in each section. There are also good screenshots of each item and as they appear on the HIS itself, and explanations of all response options that are available, as well as some item-specific tips and some good examples. The purpose of the tips is to state clarifications, issues of note, and conditions to be considered when completing HIS items. The examples do include some realistic clinical examples and can help hospices provide some good understanding and rationale, especially when they're orienting new staff to their programs. And the third chapter has information on the submission and correction of the HIS records. It also includes information on the timeliness criteria, validation of records and files, and the HIS record correction policy. The manual also has some appendices where you can find helpful acronym lists and a glossary and some CMS HQRP resources. And you can find each of the item sets in Appendix D of the manual. Okay, so we're going to do another knowledge check on what we just discussed regarding the HIS. So what type of records must a hospice complete for each patient admitted to the hospice? Choose the best answer. Is it A, the HIS admission, B, HIS transfer, or C, HIS admission and HIS discharge? And for that, to think about it. Okay, so now you've had some time. So if you did choose C, that is the correct answer. So both the HIS admission and HIS discharge need to be completed for every hospice patient who's admitted. Let's do one more knowledge check. We learned about one of the best CMS resources for questions and tips regarding the completion of the HIS. What is the name of that important resource? Is it the Hospice Quality Manager, the HIS Manual, or an experienced hospice nurse? Okay, and let's move on to the answer. So if you chose B, you're correct. It's the HIS Manual, which is available on the CMS website from the CMS HQRP page. So just to summarize this section, we reviewed the details of the HIS, and you should know how to describe the assessment types that currently comprise the HIS assessment and discharge, admission and discharge, and we identified the 3 phases of HIS reporting: the data collection, the record conversion, and then the record submission. And you should also understand that the HIS submission compliance threshold is 90% for fiscal year 2020 and onward. So now let's move on to Section 3. So this section is on the timing of HIS. The HQRP is currently pay for reporting, which means the act of submitting timely and complete data is what determines compliance with the HQRP requirements. So that is, reporting compliance is determined by successfully fulfilling both the CAHPS Hospice Survey requirements and the HIS data submission requirements. So for this lesson, we're going to focus on the timeliness criteria for the HIS. And at the conclusion of this lesson on HIS timing, you should be able to describe timely submission and acceptance of the records, distinguish between the recommended completion timing and the required submission timing for HIS, and locate at least one resource to help you understand more details about the HIS requirement. So the Centers for Medicare and Medicaid Services define the appropriate timing for both HIS completion and HIS submission. Record completion guidelines and submission requirements are in place to encourage appropriate record completion and submission of HIS records and to ensure timely quality reporting. The HIS completion timing and the HIS submission timing are separate and distinct. The guidelines for when to complete HIS admission and discharge records are only recommendations by CMS. CMS recommends that providers complete and submit HIS records well before the 30-day submission deadline to allow ample time to address any technical issues that might arise in the submission process, such as any fatal error messages. However, HIS records must be submitted and accepted by that 30-day deadline to comply with this component of the HQRP. So let's look at HIS completion and submission timing in a little more detail. So for admission records, the recommended completion deadline is defined as the admission date plus 14 calendar days. And this means that the completion date, the actual date on which the record was completed, is recommended to be no later than the admission date plus the 14 calendar days, and that the HIS admission should be completed in 14 days or fewer. It is not the same for the discharge records, however. For discharge records, it's recommended that the completion be the discharge date plus 7 calendar days. The completion date, the actual date on which the record was completed, is recommended to be no later than the discharge date plus 7 days, and means that the HIS discharge should be completed basically in less than 7 days, 7 days fewer. So although the completion timeframes are recommended, timely submission and acceptance of HIS records is a requirement to comply with the HIS reporting, and not having it in on a timely basis would mean it could impact your APU. All of the HIS records must be submitted and accepted electronically to the KEYS ASAP system within 30 days of the actual event date. So that's the admission or the discharge date. And this submission deadline is defined as the event date plus 30 days. So for HIS admission records, the submission date should be no later than 30 days from the admission date, and for discharge, the submission date no later than 30 days from that discharge date. So please note that the KEYS ASAP is a quality improvement and evaluation system, assessment, submission, and processing system. So unlike the completion dates, which are recommendations, those submission deadlines are requirements. The submission deadlines define the latest possible date that a hospice must submit an HIS record to CMS via the KEYS ASAP system for timely compliance. Hospices should have a system in place to ensure that all required item sets are submitted appropriately and on time. If a hospice realizes that it will not meet the submission deadline for a record, it should still complete and submit that record to ensure all HIS data for all patients are reported. Late submission of HIS records will result in a non-fatal or warning error. Records containing non-fatal errors can still be accepted by the system. So in addition to understanding and complying with the submission timing requirements, It's important that you also understand the record submission sequencing. When a record is submitted out of sequence, the KEYS ASAP system will issue a warning on the FVR or the final validation report. And these warnings can occur for the following circumstances. The HIS record might be submitted after the HIS-Discharge. The HIS admission record is submitted, and the prior record that was submitted was also an admission. So somewhere in there was no discharge. Also, any record submitted on a patient after the submission of a discharge record indicating that the patient had expired. It's important to note, however, that the HIS admission and discharge records may be completed and submitted on the same day. For example, this can certainly happen when a patient is admitted and discharged on that same day. So it's important that you understand a few recommendations regarding the maintenance of HIS records. It's recommended that hospices retain a copy of their HIS records along with any corrected versions. Although the signature page is not transmitted to the KEYS ASAP system, it is recommended that it be retained by the hospice for future validation purposes. Copies of HIS records can be maintained in the electronic format or in any other form. Regardless of how they're retained, proper security measures should be followed based on your agency's policies to ensure privacy and integrity of the HIS. So this lesson provided you with a lot of information about the timing of HIS completion and submission. If you have further questions regarding any of this information, you can refer to the guidance manual for completion of the HIS or the HIS manual, where you'll find lots more detail and examples as well as the tips that I mentioned. So it's now time to check another knowledge check. So please fill in the correct word for this statement. All HIS records must be submitted and blank electronically to the KEYS ASAP system within 30 calendar days of the event, admission or discharge. So is it A, double-checked, B, accepted, or C, printed? I'll give you a second to think about that answer. Okay, let's move on. Let's review the answer. If you chose B, accepted, that's correct. All HIS records must be submitted and accepted electronically by the KEYS ASAP system within the 30 calendar days of the event, which is that admission or discharge date. So let's just summarize this section on timing. As a result of completing this section, you should now be able to describe the timely submission and the acceptance of HIS records, and you should also be able to distinguish between the recommended completion timing and the recommended submission timing for HIS. And we also learned about the submission sequence, and you should be able to recognize when a submission is out of sequence and understand why the KEYS ASAP system might issue a warning on the final validation report, such as when an admission record is submitted after the discharge record. So before we move on, we're going to have a little time for some questions about these first three sections. What is the Hospice Quality Reporting Program, the Hospice Item Set, and the timing of HIS? So I'm going to turn it over to Sharon, our moderator.
Thank you, Brenda. So we did get some questions that came in. So let's get started, and I'll have Cindy, Brenda, and Deborah, one of them, to respond to the questions. Okay, the first question, so can you tell me how I get started with the HQRP? Brenda, can you respond?
Sure. Well, as we discussed in this first section of the presentation today, to be compliant with the HQRP overall, hospice providers must comply with the individual requirements for both that HIS and the CAHPS, which differ. There is a document in the download section on the HQRP webpage called Getting Started, and I'd suggest that you go to the CMS site under HQRP and bookmark that page. Once you're on that page, you can scroll all the way down to the download section, and you'll see a document that's dated September 2017. And this Getting Started PDF will help to guide you on getting started with that process. So I would definitely recommend going to look for that PDF and print it out for yourself.
Thank you, Brenda. Which hospice item set is actually required for all patient admissions? Cindy? Cindy?
Yes, thank you. Can you repeat the question, please?
Sure. Which hospice item set is actually required for all patient admissions?
So for the patient admissions, you have the hospice items, the admission item set. But for to be completely compliant for the hospice item set, you have to submit and accept both the admissions record and the discharge record for each patient.
Thank you, Cindy. Let's see. I think we have time for a couple more. If we are new providers, when do we begin reporting the HIS data, the HIS data? Brenda, can you provide an answer?
Sure. Well, there are two things to consider for providers to keep in mind with respect to the reporting. And the first is when the providers should begin reporting HIS data. And the second is when providers would be subject to that 2 percentage point APU reduction for any failure to comply with the HQRP. So as far as new providers go, these hospice providers are required to begin reporting their HIS data on the date that's noted in the letterhead of their CCN notification letter. So if you're a new provider, you will be getting a letter with that number, and the date that's on that letter is the most important. However, if the CCN notification letter was dated on or after November 1st, that hospice would not be subject to any financial penalty for failure to comply with the HQRP requirements for the relevant reporting year. So let me give you an example. If a provider CCN notification letter is dated November 15th of 2018, that provider should begin submitting HIS data for patient admissions on or after November 15th. However, since the hospice CCN notification letter was received after November 1st, they would not be evaluated or subject to any payment penalties for the relevant fiscal year, which would not be until 2020. But they should begin reporting as soon as they receive that letter. And it's important to know the distinction by CMS between when a provider should begin submitting data and when the provider would be subject to any APU reduction allows some flexibility for records that might be submitted late when the hospice first gets started and receives their KEYS user ID number. We do recommend that you save the CCN notification letter so that you have proof of the date in that letterhead, proof of when the letter was sent to you. And you can find a lot more information and details on the CMS website on the HQRP webpage.
Thank you, Brenda. I think we have ran out of time for questions for now. We do need to move on to the other sessions for this webinar. I'm going to now turn the presentation over to Deborah. Deborah, can you continue?
I certainly can. Thank you all very much. This is Deborah Dean Whitaker. I am the CAHPS Hospice Survey contracting officer's representative. That means I'm the project director for CMS. Let's talk first about our learning objectives, if you wouldn't mind going to the next slide. We have two official learning objectives. One of them is that you should be able to name at least 3 topic areas that are included in the CAHPS Hospice Survey, and also list the reasons that would exempt a hospice from participating in the CAHPS Hospice Survey. We have some exemptions that are not part of the HIS. This current slide shows the components of the HQRP that you have seen before, and notes that the HQRP is both from HIS and CAHPS. Our focus now will be on CAHPS, and that stands for the Consumer Assessment of Healthcare Providers and Systems. This survey is information obtained from hospice families and caregivers that contributes to the Hospice Quality Reporting Program. Here is some survey background. The survey was designed to measure and assess the experience of hospice patients and their informal caregivers. Informal caregivers are usually family members, and hospices tell us who they are. CMS has three major goals with the Hospice CAHPS survey. First, it provides information for publicly reported measures to help consumers and their families select a hospice. This publicly reported information is on Hospice Compare. Next, it helps hospices with internal quality improvement and also benchmarking. And finally, it provides CMS with information for monitoring the care hospices provide. Next slide, please. Now, the Hospice CAHPS survey is sent to the caregivers after the death of the hospice patient. There is, however, a lag. So if the patient were to die in January, we would not contact the caregiver to do a survey before April. The questionnaire has 47 questions, as was said before. Not all questions are asked of all people. The topics involved are important to patients and their families. We know this because we did research and they told us what was important. And there are three modes of administration, as mentioned previously: mail, telephone, and mail with a telephone follow-up. As also previously mentioned, the survey is available in multiple languages. The mail survey is available in English, Spanish, Chinese, Russian, Portuguese, Vietnamese, Polish, and Korean. The telephone survey script is available in English and Spanish. Next slide, please. I believe you've also seen this list before. These are the hospice measures. The first 6 of them are what we call composite measures. That is because they are composed of multiple questions from the survey. And the last 2 are single questions, not composite. That is the rating of the hospice and the willingness to recommend the hospice. These measures are published on Hospice Compare and you will see them as well in your preview reports. Next slide, please. Now, the CAHPS Hospice Survey is designed to be administered to the person who is most knowledgeable about hospice care received by the patient. The caregiver relationship needs to fall into a number of categories, but I think that I can just summarize by saying most commonly the caregiver is either the spouse of the person who died or the child of the person who died. We also allow other family members to fill in or friends. What we do not allow is a non-familial legal guardian who has nothing to do with the care of the patient. They cannot be asked. The hospice is responsible for identifying the primary caregiver who may be eligible to receive and respond to the survey. This page here, this slide shows some of the requirements for eligibility, such as the decedent has to be 18 or older. There are additional requirements. We would ask you to go to the Quality Assurance Guidelines Manual for details, and that can be found on the survey website. I also would like to make one other point. The last bullet here talks about no publicity. No publicity patients should be rare. We are looking at this as something that should be in the rare case that an individual might receive publicity and that they would not want it, and that they must, or their family member must, voluntarily initiate the request for no publicity. This does not mean that you can, as a hospice, ask anybody, do you want publicity? Or do you want to answer a survey? It needs to be we see this as a rare occurrence, not something that would apply to the most of your patients. Next slide, please. Let's talk about participation requirements. All medically certified hospices must participate in the CAHPS Hospice Survey unless they're exempt. I'll talk about that later. They must successfully submit data for all 12 months of the data collection year, and that year runs from January through December. It's a calendar year. We are currently in the 2018 data collection year. The hospices must contract with a CMS-approved vendor. We have quite a long list. You can find that on our website. The hospices must provide decedent caregiver data on the patients, regardless of payer source, to their survey vendor. Do this on a monthly basis. Now, there are additional specifics that you can find out more about by looking at the Quality Assurance Guidelines Manual, as I mentioned. Now the slide is showing you the hospice survey process. You'll notice it starts with the hospice itself. You are providing the names of the patient's caregiver and the other information we ask for to the survey vendors, and they create the sample and conduct a survey. Then they engage in quality checks, and your vendor submits data to the CMS data warehouse. You will notice I have a little sign here that says success is critical. If the vendor does not successfully submit data to the CAHPS data warehouse, then the hospice would be out of compliance. It is important, therefore, to have somebody in the hospice look at reports from the data warehouse on a regular basis to make sure your vendor is doing what they said they would do. You can get access to the Hospice CAHPS data warehouse. It's completely free. You go to the website, the survey website, and apply, and you will get access to the reports. Here is my suggestion. I would say make a mark on your calendars. Data submission deadlines are the second Wednesday of the month for the months of February, May, August, and November. So I would say make sure you know when you expect your vendor to submit your data. Go in and check your reports to make sure that they submitted the data successfully, because your compliance depends upon their success. Next slide, please. Now, this next slide talks about what we are putting on Hospice Compare. It is called the top box scoring, and what that means is that we are reporting the most positive response. Now, that varies by question. So for some questions, we ask, how often did this happen? Never, sometimes, usually, always. And most frequently, the always is the most favorable response. We do have one question that says, how many times did the hospice give you confusing or contradictory information? Clearly, then never would be the most positive response. Yes, definitely is the most positive response, the right amount. A 9 and 10 on a scale from 0 to 10 or 1 to 10 would be the most positive response. So we are trying to measure what percentage of the people responding to the survey are giving you the most favorable response if you're a hospice. Let's go to the next one. The next slide, please. All right, now we're going to calculate a top box score. What you say in the numerator, it's the number of respondents who selected the most positive response, and that's divided by the number of respondents who answered that question. Now, that is an unadjusted score, and that is at the item level. When we're talking about our composite measures, of course, we may have more complex calculations, and indeed, all of our data is adjusted. I will explain that in a minute. But the basic calculation is what percentage of the respondents are providing the most favorable response. Next slide, please. Now, the difference in hospice ratings should reflect differences in hospice quality. We adjust our results to level the playing field. We make two sorts of adjustments. One is mode of survey administration, and the other is case mix. Case mix addresses differences between hospice populations, and mode adjustments addresses differences in the mode of survey administration. All results are adjusted for both of these, both case mix and mode, and this happens before they are publicly reported. It is important to notice this because adjusted results are the official CAHPS survey results, but they may differ from the results you get from your survey vendor because most survey vendors do not provide adjusted results. That's not anything against the vendor. They're accurate results, but they just simply are not adjusted results. Next slide, please. Let me talk a little bit more about the adjustments. We know that certain characteristics in the population may impact how people respond to survey questions. For example, older caregivers and younger caregivers may consistently respond differently. There is some evidence that caregivers tend to be more favorable in their assessments than younger caregivers. Okay, what does that mean? Well, it means that if you have Hospice 1 and Hospice 2, they provide exactly the same quality of care. But Hospice 2 has older caregivers and Hospice 1 has younger caregivers. Hospice 2, therefore, will have a higher rating probably than Hospice 1. Why? They have older caregivers. So the idea with the adjustment is to get rid of that kind of difference so that the only thing left is what is the quality, and that's what you see on the right, an even balanced proportion between Hospice 1 and Hospice 2. We also, same thing with mode adjustment. We know that people tend to answer differently based on the mode, and sometimes more positive, sometimes less. So we try to adjust for that as well. So it's not simply they're getting a better score because they talk to them on the phone. Next slide, please. Now, one of the things that's very important here is that caregiver responses must be based only on the hospice care. And hospices and vendors must not attempt to influence how caregivers respond. The Hospice CAHPS survey should be the first survey that caregivers receive about their family member or friends' experiences in hospice care. And the hospice and the survey vendor must not attempt to influence how you respond. So you don't want to say, well, please give us a 10. Don't do what the car dealers do. We don't want that. That's attempting to influence the results. Don't do anything that is likely to, don't say anything that is likely to say, well, our people will get an extra amount of money if you say yes. Or just, you can tell people that to expect the survey. You must tell everybody if you do that, but don't try to influence what the results will be. Also, the Hospice CAHPS survey results are intended for quality improvement, not for marketing and promotional activities. And here are some things that we would ask survey vendors and hospices not to do. Don't ask hospice survey questions of caregivers before you administer the survey. Don't attempt to influence or encourage caregivers to answer survey questions in a particular way. Don't imply that the hospice or the staff will be rewarded for positive feedback. And do not ask caregivers to explain why they chose a specific response. Please take a look at the Quality Assurance Guidelines Manual for more details. Next slide, please. Okay, let's talk about exemptions. A hospice may be exempt from participation in the CAHPS Hospice Survey if it has served fewer than 50 survey-eligible decedent caregivers during a calendar year. Size exemptions are based on patient counts from the previous year, which is the reference year. So if the survey data is being collected in 2019, the reference year is 2018, and the question is, did you serve fewer than 50 survey-eligible decedents and caregivers during 2018? I'm not talking now about average daily census. It's total number of decedents in the prior or reference year. The exemption is active for only 1 year. If you remain small and remain eligible, you'll need to reapply each year. You need to submit a participation exemption for size form. It can be found on the survey website, and it basically is a worksheet to help you work down to see whether or not you have fewer than 50 survey-eligible decedents. So for small hospices, there is potential for a survey exemption for size, and that can continue year to year, but you must apply for it. The other exemption is for newness, and this depends upon when you have gotten your Medicare certification number. If you get your Medicare certification number, CCN, on the first day of the performance year of the survey, or after that time, you are exempt. So, for example, for this year, if you got your CCN on or after January 1st, 2018, you're exempt from data collection from January through December of 2018. This is a one-time exemption and identified by CMS. You do not need to apply for the newness exemption. Those are the two exemptions we have. Let's go on to the next page, please. Oh, and we have a knowledge check. All right, let me read this to you. The objectives of the CAHPS Hospice Survey are to provide information to assist hospice patients and their families in selecting a hospice. B, aid hospices with internal quality improvement. C, provide information to CMS for monitoring hospice care. D, provide marketing information for hospice agencies. E, A and B, and F, A, B, and C. I'll wait just briefly, and then we can find the answer. Let's go on to the answer, please. The answer is F, A, B, and C. It's to provide information to assist patients and families with selecting a hospice, to aid hospices with quality improvement, and to provide information to CMS for monitoring hospice care. And next slide, please. Okay, having concluded this particular lesson about hospice CAHPS, I hope you now will be able to name some of the topic areas included on the CAHPS Hospice Survey and also list reasons that would exempt a hospice from participating in the CAHPS Hospice Survey. Thank you very much, and that's all for CAHPS.
Thank you, Deborah. This is Brenda again, so I'm going to move to our last section, which is Section 5. And in this section, we're going to talk about Hospice Compare and public reporting. So the learning objectives for this section are, at the conclusion, you should be able to explain what information can be found on Hospice Compare, discuss some of the benefits of Hospice Compare for patients, families, and for hospice providers, and describe the hospice quality measures, or the QMs, reported on Hospice Compare. So we've talked about the HQRP, but we haven't talked about Hospice Compare or how that came about. The Affordable Care Act actually requires the public reporting of hospice quality measures on a CMS website, and that CMS website is Hospice Compare. It was launched in August of 2017. So Hospice Compare reports information on hospices across the nation and allows patients and family members and healthcare providers to get a snapshot of the quality of care that's provided by each of the hospices. Hospices can be compared based on important indicators of quality, and the Hospice Compare website includes the HIS, or Hospice Item Set measures, some CAHPS survey measures, and some other pertinent data. So the goal of Hospice Compare is to assist the consumers in making some decisions that are right for them by allowing them to compare the quality of the care that's provided in the hospices near their home or where they live. Through that site, patients and family members can obtain that snapshot, and they can actually pull up like 3 different hospices and compare them side by side. They can also compare them based on quality measures like the percentage of patients who were screened for pain or received a comprehensive assessment for pain on admission, or who were asked about their preferences for life-sustaining treatment. And as hospices, you can use Hospice Compare to help you better understand how you're performing against your peers or the national averages. Through regular updates, you can work continuously to improve your quality scores and track performance. And this data could really be invaluable when assessing the impact of your quality improvement efforts and evaluating some best practices by comparing them quarter to quarter. So let's take a look at what's on the Hospice Compare website just to see what information is available. Consumers can search for all the Medicare certified providers by name, by city, or by zip code. So for each hospice that comes up in the search, an address and telephone number is listed along with the information and some ownership information that also says whether they're a for-profit or a not-for-profit organization. And then the date of their CMS certification, so how long they've been working as a hospice. Consumers can also review the quality measures for each hospice and see how the hospices compare to the national averages and to each other if they pick a few hospices to compare. So there are 7 HIS-based quality measures reported on Hospice Compare, and remember these are based on the HIS admission records that you submit. Items on the HIS admission record are used to calculate 7 National Quality Forum, or NQF, endorsed measures, which are updated on a quarterly basis. And you can see the quality of care area of the page has 2 subcategories, patient preferences and managing pain and treating symptoms. And in addition, if you put your mouse over the name of the measure, additional information will come up about the measure and why it's important. And by clicking on the table and the graph tabs, you can see the graphs appearing on this slide. So you can see the results of each measure and the percentage as it compares to the national averages. So in the first group, the patient preferences, it contains 2 measures. The treatment preferences, and this is the percentage of patient stays with chart documentation that the hospice discussed or attempted to discuss preferences for life-sustaining treatment. And then there's beliefs, values, if addressed, if desired by the patient. The percentage of patient stays with documentation of a discussion of spiritual or religious concerns, or documentation that the patient or the caregiver did not want to discuss that. They might have refused, and that's fine as long as it was documented. So the second group, managing pain and treating symptoms, includes the following. Pain screening, which is the percentage of patient stays during which the patient was screened for pain during that initial nursing assessment. Pain assessment, the percentage of patient stays during which the patient screened positive for pain and received a comprehensive assessment of pain within 1 day of screening. Dyspnea screening, which is the percentage of patient stays during which the patient was screened for dyspnea during that initial assessment. And dyspnea treatment, which is the patient screened positive for dyspnea and received treatment within 1 day of the screening. And then the last is the patients treated with an opioid who are given a bowel regime. So this is the percentage of patient stays during which a patient treated with an opioid was offered a prescribed bowel regimen or documentation of why that might not have been needed. So Hospice Compare also includes measures based on the information from the CAHPS Hospice Survey, as Deborah discussed. We talked about how hospices are required to conduct this survey with family and friends who cared for the patient who died under the hospice's care. And the survey is conducted on a monthly basis with the family and friends are contacted 2 months after the patient's death. So beginning in early 2018, Hospice Compare began displaying 8 CAHPS measures. And the information from this survey includes the communication with the family. And this measure covers how well the hospice kept the family informed of arrival, how well things were explained in a way that was easy to understand, or whether the staff listened carefully about problems. As Deborah talked about, these are composite measures. Then it includes getting timely help, and this covers questions about how soon the hospice responded to a family member's request for help, how often they received the help needed during evenings, weekends, or holidays, treating family and patient with respect. This covers how often the hospice treated the family member with respect and whether the family felt that the hospice team really cared about their family member. And then another is emotional and spiritual support, and this covers how much emotional and spiritual support the hospice team provided to the patient and the family and how well they felt supported. Then there's help for pain and symptoms, and this measures how often the family member received the help he or she needed with pain, trouble breathing, trouble with constipation, or feelings of anxiety or sadness, for example. And then there's training to care for the patient, and this covers whether the hospice team provided family members with some training and assessing the need for side effects of pain medication or dealing with breathing problems, agitation, or even restlessness. And as Deborah mentioned, there are 2 individual measures. These are not composite measures, but then there's rating this hospice. And this measure asks the family member to rate the care the hospice provided on a scale of 0 to 10, with 0 being the worst and 10 being the best. And lastly, the willingness to recommend this hospice, and this measure asks the family member, whether they would recommend the hospice to family and friends. So CMS recognizes that the public reporting of quality data is a vital component of any robust quality reporting program, and they're fully committed to developing the necessary systems for transparent public reporting of hospice quality data. And in establishing the procedures for making these available to the public, each hospice program has the opportunity to review their data before it's made public. So CMS also recognizes that it's essential for the data to be made available. That has to be meaningful to the public. And comparing performance between hospices requires that they construct measures from the data that was collected in a standardized and uniform way, as they do in the HIS and the CAHPS. CMS does make reports like the provider preview reports available to providers so that they can preview their data before it becomes public. So let's just talk a little bit about the provider preview reports. These are available through the Certification and Survey Provider Enhanced Reports, or the CAHPS reporting program. And these reports are automatically generated every quarter, and they're placed in the hospice's shared folder in CAHPS. And these reports give providers an opportunity to preview their hospice's HIS and CAHPS hospice survey data that is going to be publicly reported before it's posted on the Compare website. Providers have 30 days during which to perform their review, and these reports are provided after the freeze date, after which providers cannot make changes to their HIS records. And because of this, hospices are not able to make changes to the underlying data. Providers need to take action to ensure all the data is accurate prior to that freeze date. And if hospices fail to make necessary corrections to their HIS data before the freeze date, then CMS will base the measure on the data that was in the CMS system at the time the quality measures were calculated. If a hospice believes the data are inaccurate due to an issue such as CMS calculation issue, they can request that CMS review it for suppression from Hospice Compare. And any such request must be made during that 30-day provider preview period. It's important to note that inaccurate data due to a provider-made errors on the HIS is not a valid reason to request CMS review of the data. All requests for CMS review must be submitted during that 30-day preview period. So more instructions on how to access the reports or to request a CMS review are available on the CMS Hospice Quality Reporting Program website, but they're also detailed in the webinar that we had on May 30th, and that can also be found in the HQRP training library. Hospices are encouraged to download and save their reports because they are available in CAHPS for only 60 days from the report's release date, and after that they're not accessible, so it's good practice to download them so that you have access to them. So I'd like to tell you about two other reports that can be used to monitor compliance, and that's the Hospice Timeliness Compliance Threshold Report and the Final Validation Report. So the Hospice Timeliness Compliance Threshold Report is an on-demand, user-requested report that shows your hospice's current timeliness compliance percentage. So it shows the number of HIS records that were submitted, the number of HIS records that were submitted on time, and the percentage of HIS records submitted on time. It's important to track these reports to ensure that you're meeting the timeliness thresholds, which can impact your compliance. The Final Validation Report is used to verify that HIS record submissions have been successfully accepted into the KEYS ASAP system. If there are any warnings or errors, the hospice has to investigate and follow up. This is one way to ensure that the data that contributes to your quality measures are accurate and that it's been accepted into the system. So when looking at Hospice Compare website for some agencies, you might notice that the website says that the results are not available. Now remember, the data to compute the QMs comes from the HIS data that the hospices submit. Hospices that have fewer than 20 patient stays will not have their quality measures publicly displayed because a score with such a small denominator is not reliable. So if you are one of these hospices, you should keep that in mind. This data will be reported on your hospice preview report regardless of the denominator size. And you can access and see your data on the CMS website, data.medicare.gov, which provides direct access to the official data that are used on the Medicare.gov Compare website and the directories. So here's another knowledge check. Hospice providers need to review which of the following: the provider preview report, the final validation report, the hospice timeliness compliance threshold report. D, A, and B are the right answers, or choose E, A, B, and C. I'll give you a minute to think about that. I think we can move to the answer. So if you chose E, that is correct. You really should review not only the provider preview report, but also the final validation reports and your hospice timeliness compliance threshold report. So reviewing all of these on a regular basis will really help keep your hospice on track. Let's go to one more knowledge check here. So select the correct word number to complete the following statement. Quality measures on Hospice Compare are updated how often? A, weekly, B, quarterly, or C, monthly? So the answer is B, quarterly. Quality measures on Hospice Compare are updated quarterly. Okay, so let's just summarize this last section on Hospice Compare and public reporting. After completing this, you should hopefully understand the information that you can find on Hospice Compare, such as the Medicare certified hospice providers by name, by city, by zip code, their owner status, the quality measures, and how they compare to the national averages. And you should also understand the benefits of Hospice Compare for patients, families, and hospice providers, and be able to describe the hospice quality measures that are reported on Hospice Compare. So I want to make sure you know that there are numerous resources on CMS's website, and you should, if you want to read more, you can visit the Hospice Quality Reporting webpage using the link located on this slide. And on the website, you can also find information such as announcements, updates, previous trainings, preview reports for HIS-based quality measures and CAHPS survey results. And let's review some of the resources for CAHPS on the next slide. So the official website for announcements, updates, and general information on the CAHPS Hospice Survey is www.hospicecahpssurvey.org. And should you need to contact the CAHPS Hospice Survey team for information and technical assistance, you can email or call using some of the phone numbers and the email addresses on this slide as well. So now we're going to move on to a few more questions that have been posed by hospices, and I'm going to turn it over to Sharon.
Thank you so much. We do have a few minutes before we have to close out. First question, can you clarify who must participate in a CAHPS hospice survey? Cindy.
Sure. In general, all Medicare certified hospices need to participate in the CAHPS Hospice Survey in order to receive their full annual payment update.
Thank you. Next question is, what is Compare? Brenda? Brenda, can you take that question?
Yeah, this is Cindy. I'm happy to respond. The Hospice Compare is the vehicle by which CMS publicly displays hospice data. The goal of Hospice Compare is to help consumers compare hospice providers on their performance and assist them in making decisions that are right for them. When appropriate, providers can inform their patients and family members about the new Hospice Compare website and explain that the Hospice Compare website provides a snapshot of the quality of the care a hospice offers. They can encourage patients and their family members to review quality ratings and use their site to help patients and family members make the best decisions for the care. You can find more information about Hospice Compare at the website, which is the www.medicare.gov/Hospice Compare. Thank you very much.
Thank you, Cindy. The next question, how often is the CAHPS Hospice Survey conducted? Deborah, can you respond, please?
Yes, it's conducted monthly. So you should be giving information to your vendor monthly. There is a lag. So when you give information on your January decedents, that will then impact the sample for April. But the survey is conducted continuously every month. And your data collection year runs from January through December of the calendar year.
And Deborah, can you take this next question? How does my hospice have to get a specific number of responses to comply with the CAHPS Hospice Survey requirements?
The answer to that question is no. You do not need to have a specific number of responses to be considered compliant for the annual payment update. However, in order for your data to be published on Hospice Compare, you must have at least 30 complete surveys over the last 8 quarters.
Thank you, Deborah. I think we have time for maybe one more. Brenda, can you review the current measures reported on Compare for HIS?
Sure. So, yes, there are currently 7 quality measures reported on Hospice Compare, and these are the patient treated with an opioid who are given a bowel regime, pain screening, pain assessment, dyspnea treatment, dyspnea screening, treatment preferences, and beliefs and values if addressed and desired by the patient. So the timeline for public reporting of the hospice and palliative care composite process measures, the comprehensive assessment at admission, and hospice visits when death is imminent measure is still to be determined. Hospice can look for future updates to the Compare website on the HQRP Spotlight and Announcements page.
Thank you.
I just wanted to add to that with the final rule this year, we have added the composite measure that's going to be going on this November of 2018 with the next Hospice Compare refresh, and that composite measure is a composite of these 7 component HIS measures. And then later this year, we will be reporting the death is imminent measure pair, which was also discussed in our final rule this year. So we will be having additional measures coming on to Hospice Compare with the fiscal year 2019 period.
Thank you, Cindy.
Thank you, Cindy.
We're out of time for today's webinar. Just keep in mind some of the questions that were submitted today. We apologize, but those questions will come up and be showed later on the CMS Hospice Quality Reporting Program webpage, where all responses to questions submitted today will be posted later. This concludes the webinar for today. Just before I end, I just want to say thank you to Brenda, Cindy, and Deborah again for sharing your knowledge. And please keep in mind that a full version of the slides, including the answers to polling questions, and a recorded version of today's webinar will also be posted at the Hospice Quality Reporting Program website. Thank you so much, everyone, and thanks for attending. This concludes the webinar.
This concludes today's webinar. Thank you all for attending.